To the topic Pemphigus vulgaris in the Dermatology module. By the end of this topic, you should be able to define Pemphigus vulgaris, explain the pathophysiology and risk factors associated with Pemphigus vulgaris, describe the clinical features of Pemphigus vulgaris, list the differential diagnosis of Pemphigus vulgaris, outline the investigations to diagnose this condition, and discuss the principles of management. Let's get started. The term pemphigus is derived from the Greek word pemphix, which means bubble or blister. Pemphigus vulgaris is a rare autoimmune intraepithelial blistering disease affecting the skin and mucous membranes, most commonly inside the mouth. Its peak incidence is usually between the ages 30 to 60. Now let's discuss the pathophysiology and causes of Pemphigus vulgaris. Pemphigus vulgaris is a result of a type 2 hypersensitivity reaction in IgG autoantibodies binding exclusively to the desmoglein component, which is a cadherin-like adhesion molecule, specifically desmoglein 3. This protein is found in the desmosomes in the keratinocytes near the bottom of the epidermis. As a result, the keratinocytes separate from each other and is subsequently filled with fluid. Thus, there will be loss of intercellular connections in the epidermis, leading to painful blistering and erosions. Do take note, any minute shearing forces will shear off the entire epidermal layer. This is an autoimmune disorder, but the exact cause is not fully understood. It has been suggested that Pemphigus vulgaris may be due to genetic factors and is triggered by environmental factors such as ultraviolet rays, infections, diet and drugs such as NSAIDs, rifampicin and antibiotics. Interestingly, it was found that Pemphigus vulgaris occurs more commonly in people who have other autoimmune diseases, particularly myasthenia gravis and thymoma. Some things for you to keep in mind is Pemphigus vulgaris is not contagious, and although there is a genetic predisposition to develop this condition, there is no indication that Pemphigus vulgaris is hereditary. Let's move on to the clinical manifestations of this condition. Pemphigus vulgaris first presents with lesions on the mucous membrane, mouth being the common area seen in 50 to 70% of patients. A few weeks later or months, the blister develops on the skin. Do take note that in some cases, the mucosal lesions may be the sole manifestation of the disease. Blisters in the mouth are often superficial and erosive, which turn into painful sores and are slow to heal, making brushing, eating, and even drinking very difficult. The patient's voice may become hoarse if the blisters spread to the larynx. Lesions on the skin usually appear as thin-walled flaccid blisters filled with clear fluid that easily ruptures, causing itchy and painful erosions. The affected skin is often painful but rarely pruritic. They don't usually leave any scars, but the affected skin occasionally becomes permanently discolored. This most likely arises on the upper chest, scalp, face, and back. Any erosions in the skin folds may develop into vegetative lesions, which are granular and crusted, often known as pemphigus vegetans. Additionally, the skin around the nails may be swollen, painful, and red. Other areas that may be affected include areas of the digestive system's soft tissue lining, such as the nose, throat, anus, vagina, and genitals. Nasal involvement causes congestion and bleeding, and lastly, the conjunctiva can also be affected. In addition to what was mentioned in the previous slides, there are certain other signs that can be elicited to support our suspicion, and this includes the Nikolsky sign. Nikolsky sign is usually done in patients with active blistering, hence you apply a firm sliding pressure with the finger separating normal appearing dermis, producing an erosion. In simpler terms, it means you rubbed next to a blister and made a new one. This sign is, however, not specific for Pemphigus vulgaris, and as a positive sign, it also is seen in other active blistering diseases such as toxic epidermal necrolysis and Stevens-Johnson syndrome. Next is the indirect Nikolsky sign, also known as Esbo-Hansen sign. Here again, you apply a pushing down on the blister and making it spread bigger into clinically affected skin. Again, bear in mind that this too is a non-specific sign and could indicate other active blistering diseases. A positive Nikolsky sign means you rubbed next to a blister and made a new one. The related indirect Nikolsky is pushing down a blister and making it spread bigger. also known as Espo-Hansen sign. However, not everything that has a positive Nikolsky is pemphigus. Establishing the diagnosis in patients who present only oral lesions is more difficult than those in the mucocutaneous conditions, as these oral lesions may mimic other diseases too. Therefore, there are few differential diagnoses that can be considered when you think of pemphigus vulgaris. Firstly, being bullous pemphigoid. Aggressive bullous pemphigoid may mimic pemphigus vulgaris. However, bullous pemphigoid occurs most often in older people and is characterized by tense blisters of the skin. It's also rarely involving the oral mucosa. Secondly, you should consider pemphigus foliaceus. But one differentiating factor is that this condition is confined to the skin and there is little or no involvement of the mucous membrane, unlike pemphigus vulgaris. Next, there is paraneoplastic pemphigus, and this is easily confused with pemphigus vulgaris as paraneoplastic pemphigus when it's characterized by painful blisters and denuded areas of the mouth, lips, esophagus, and skin. Moving on to Stevens-Johnson syndrome, oral lesions mimic pemphigus vulgaris. However, it is usually a reaction to medications like antibiotics that starts with flu-like symptoms followed by painful rash and spreads becoming blisters. Just like pemphigus vulgaris, Stevens-Johnson syndrome has a positive Nikolsky sign. Then there is familial benign pemphigus or Hailey-Hailey disease. A very obvious differentiating factor is that familial benign pemphigus does not involve the oral mucosa. Moving on to linear IgA bullous dermatosis, this clinically mimics bullous pemphigoid and thus pemphigus vulgaris. There is a predilection for the extensor surfaces with symmetric distribution and lesions unseen on the elbows, knees, and buttocks. Now let's look at oral lichen planus. This can resemble the erosions of pemphigus, but typically this also has lichenoid appearance with a net-like reticulated pattern. And lastly, you should also consider dermatitis herpetiformis. However, this usually starts in adolescents or young adults, developing in spurts with spontaneous remissions. Remember, this is not an exhaustive list of differential diagnoses. There are many more to consider. In terms of investigations, the first investigations to order would be a skin biopsy from the skin adjacent to the lesion for hemocyanin and eosin staining, as well as for direct immunofluorescence. Remember that biopsies of erosions often result in a false negative test as there's no epidermis for interpretation. In the case of skin biopsy for hematoxylin and eosin stains, the basal cells lose their adhesion to adjoining keratinocytes while maintaining adhesion to the basement membrane. This gives a tombstone appearance as seen in the picture and on the top right. A biopsy demonstrating classical findings of pemphigus is generally diagnostic, but other conditions as mentioned in the differential diagnosis may have similar histological hallmarks. Next, skin biopsy for direct immunofluorescence is considered as the most pathognomonic test. In the presence of pemphigus vulgaris, IgG, C3, or both is seen to be deposited in a broad linear band on the surface of the epidermal keratinocytes in the suprabasilar regions of the epidermis. You can also conduct serological investigations, and these include indirect serum immunofluorescence, serum ELISA, and serum immunoblot or Western blot assay. In indirect serum immunofluorescence, this applies the patient's serum to a substrate and look for the presence of autoantibodies that will stain with the substrate, supporting the diagnosis of pemphigus vulgaris. As for serum ELISA, it is specifically looking for autoantibodies, particularly desmoglein 1 and 3. Now let's discuss the appropriate management for pemphigus vulgaris. The objectives of the treatment are to heal the blisters and minimize or resolve any associated functional impairment, to reduce future exacerbations, to improve the patient's quality of life, and to limit common adverse effects associated with long-term immunosuppressive or corticosteroid treatment. For mild pemphigus vulgaris, prednisolone or with or without azathioprine or mycophenolate is recommended. Rituximab with or without adjunctive corticosteroid is an alternative first-line therapy. For moderate to severe pemphigus vulgaris, rituximab is in association with prednisolone prescribed as tapering dose can be given, however needs to be stopped after 6 months and is usually given as a first-line therapy. If rituximab is contraindicated, then prednisolone with azathioprine or mycophenolate can be given instead. Patients with severe or refractory pemphigus vulgaris can be recommended intravenous immunoglobulin, intravenous corticosteroid pulse therapy, or immunoadsorbent therapy. Remember, serum IgA deficiency must be ruled out prior to intravenous immunoglobulin treatment as it is a contraindication. When it comes to supportive therapy, that should be considered in all patients, which include appropriate dental care, intralesional injection of corticosteroids, adjuvant treatment with super potent topical corticosteroids, antiseptic baths, analgesia, and nutritional management with the help of a dietitian. Let's summarize what we have covered so far. Pemphigus vulgaris is a rare autoimmune intraepithelial blistering disease affecting the skin and mucous membranes and most commonly inside the mouth. It occurs due to IgG autoantibodies against desmoglein 3 within the epidermis, causing an intraepidermal split in the skin. It has been suggested that pemphigus vulgaris may be due to genetic factors and is triggered by environmental factors. The clinical presentation of pemphigus vulgaris is flaccid, easily ruptured blisters, forming erosions and crusts, and these lesions are often painful and usually affecting the mucosal area, which may precede skin involvement. Investigations-wise, skin biopsy for hematoxylin and eosin stain, as well as for direct immunofluorescence is considered. Serological investigations can also be ordered if necessary. Management is based on severity of the disease. However, corticosteroids and immunosuppressants are usually prescribed. Supportive treatment in addition to pharmacological treatment is also very beneficial. We have come to the end of this topic. Thank you.